Hello, I'm Dr. Thomas Schuler, Chairman of the Medical and Scientific Board of the National Spine Health Foundation. We're interviewing the top spine specialists around the nation to find out what you can do to overcome your back problem or your neck problem. I'd like to welcome you to Spine Talk Cities 2020.
Another question, with so many advancements in technologies, and we're always reading about all these things, if I'm a patient who's suffering with a spinal problem, how do I decide, is it the right time to treat? Is this something I should be waiting for a better technology to come in the future? How do I make those decisions and stay up to speed on what the best thing is, as there's a lot of information out there?
People come and say, oh, my neighbor said I should never get spine surgery because no one does well with spine surgery. I said, well, actually, that's not true. We're in a world where if you pick the right diagnosis and the right treatment for the right diagnosis, we achieve over 90% of patients doing very well with a very low need for a revision rate, because that's the other thing people come in or said, well, isn't it true that every time if you have spine surgery, you're going to need to have another spine surgery? I said, well, that's not actually true either. But the genetics you come to me with, meaning your mom and dad, whatever they gave you, you're going to leave the operation with. And if there's a history of a lot of arthritis in your family and all these things, you may get it at another level. Just like a person who has a knee replacement and has a knee replacement on their right knee, when they come back a year later and they need a left knee replacement, or 2 years later, they don't blame their right knee replacement for their left knee replacement. But if they have a herniated disc at C6, 7, and they get a beautiful result from treatment of that herniated disc, when a year later or 2 years later, their C5, 6 disc herniates, it is not really the fault of that 6, 7 operation, but it always seems to get blamed for it. And that's just another common misconception within spine surgery that's loomed over us, I think.
Sometimes people with very large deformities of the spine or scoliosis conditions do require open surgery, which is essentially a big, long incision in the middle of the back, dissecting and exposing all of the bone and doing all of those types of bone cuts in an open fashion. There are some people where the conditions are just too great despite our technological advances. Other types of open surgery are if you have some sort of tumor. So certain tumors of the spine, or unfortunately cancers of the spine, a lot of those just have to be removed. And although minimally invasive techniques have allowed some of those to be treated through smaller incisions, at the end of the day, if the goal is to get the tumor out, then sometimes an open surgery is just the best overall for the patient and for you.
If the surgeon feels that a fusion is appropriate because the spine is unstable or there's a lot of degeneration, that's when we consider doing fusions. And so there's various techniques of making an incision in the front and doing this procedure called a retroperitoneal exposure. But then there's laterally based procedures, and then there's posteriorly based procedures. But one of the reasons why you take the disc out itself is that increases your overall surface area to do a fusion. In other words, to get that segment solid. But then also the advantage of doing this technique, which is called a transforaminal lumbar interbody fusion, is you can restore the height of the disc to its normal non-degenerative height. You can also reduce a slip called a spondylolisthesis. So there's various reasons why we do that technique. And most surgeons now are doing TLIFs very, very commonly because they are kind of, I believe, the workhorse of treating many conditions in the lumbar spine.
When there was trauma in the cervical spine, when I trained with Henry Bowman, we just had wires. Well, now you have pedicle screws, you have translaminar screws, you have facet screws. And for the public, these are just different structures of the back of the spine, but it allows us to put screws into these different elements to hold the bones together while they heal. Whereas before, we used to put patients in a halo, which is a metal ring around their head with pins in the front and the back. Now we can take the most complex fractures, we can limit the number of areas that we fuse. For example, in some of the fractures, we would have to fuse from the back of the skull down to the mid portion of the cervical spine. And that is a very debilitating fusion because you lose your rotation and a lot of bending up and down. Now, with these special techniques, we can just fuse, for example, the upper two segments together rather than doing from the skull down to, say, the C3 level. So tremendous advances in the internal fixation and stabilization of the spine, again, which all translates to minimally invasive surgery and less destruction of the normal tissues.
Say someone has a herniated disc and needs a surgery, and they've already had a surgery for it. So they herniated their disc, they have leg pain, someone did a microdiscectomy, removed the disc, and they felt great for 6 months. And now they're coming back in and the disc has come out again. When you look at the literature suggests that even if you were to go in with a small surgery and remove the disc, there is a significant number, depending on where you read, anywhere from 15 to 35%, who will need a third surgery afterwards. And so at this point, you're sort of at equipoise. And do you do the small surgery, which is going back in, taking out that disc again? Or do you go for the definitive surgery, which is a fusion? You take out the entirety of the disc, you put in a cage, you put in the screws, rods, and it sounds a lot bigger and the recovery is a lot longer. In my personal view, there's no right answer, and it really depends on the risk tolerance of you as the patient. There are some people who would rather go for the small surgery. They can sleep at night, and if they have to come back in 6 months with a fusion, then they were happy with that gamble. And there are other people who, the first time failed, let's be definitive. I'm happy with either way because in this way, it's a relationship and contract that I have with the patient. I typically am not very patriarchal when it comes to these. If they ask me what I would do, then I would tell them. In this case, personally, I would probably go for the fusion up front, but I also qualify by saying that I'm very risk tolerant and I'm very definitive. And it goes to show my belief in these procedures, but it also goes to show that that's my spectrum on my direction. So I'm there to help people make their decisions. And if at the end they really don't know, then I'll give them sort of an opinion in that way. So if you have a herniated disc and you get leg pain, that's typically where you present to, say, your primary doctor or your ER and are told that you likely have a herniated disc. If you get an MRI, you can get confirmation. But the pathway for a herniated disc, the condition is not dangerous, right? It's painful for sure because it's nerve pain, but it's not dangerous. The spine isn't going to fall apart. The majority of the time, the nerves are fine. And so in the majority of cases, there's time to pursue anything that can relieve the pain. A lot of the times it's the pressure, and a lot more of the times it's just the irritation and inflammation of the nerves themselves. So that's why a lot of the initial non-surgical treatments such as therapy, massage, traction, chiropractic manipulation, all of those things aim to increase the flexibility of the spine, reduce the irritation and inflammation to make you feel better. And if you feel better, that's all that matters. When you get into things like injections and surgery, that's where things haven't worked. And thankfully, that is a smaller percentage of the population. So, chances are if you're looking at this video, if you're looking at it online, over 9 out of 10 times, you will be fine. But for that 1 out of 10, less than 1 out of 10, this is where a lot of the information becomes more pertinent, especially if you're talking about surgery.
Doing a less invasive procedure, particularly through a tube, whether you're going to add a fusion to it or not, it really relies on being able to see normal anatomy and navigating off of that normal anatomy during surgery with what you're seeing and what you're feeling on spine. And when there's a lot of scar tissue, it becomes a little bit more problematic. But for simple things of the spine that cause potentially big problems for a patient, for example, foraminal stenosis, which is a pinched nerve in the lumbar spine, oftentimes that can be treated very successfully through a small incision, whether it's through an endoscope, which is a fantastic option for many patients at levels above L5S1, so L2, 3, 3, 4, 4, 5, are pretty good options if a patient's got a nerve pinched as it exits the spinal column. On the other hand, less invasive options are pretty good for focal, meaning 1, maybe or 2 level spinal stenosis, which is causing unilateral or left or right sided symptoms, and certain cases of 1 or 2 level stenosis, which is causing bilateral or both sides being involved in terms of the pain, can be treated through a less invasive option. But when you're talking about big deformity surgery or tumor surgery or infection, those sorts of things should be treated with a traditional open approach.
Many surgeons say they're minimally invasive, but they're also minimally effective. In other words, they're not treating the pathology just like you and I would do with an open procedure. I can tell you, when I do a minimally invasive procedure, I expect the exact same surgical outcome at the time of completion of the surgery. In other words, get the job done, right? If they have a disc problem, address the disc problem. If they have a degenerative process where they need a fusion, address that. So it should look exactly the same radiographically when you're done. The real only difference is that they have less of a surgical trauma, which then leads at least potentially to better outcomes, less blood loss, less infection risk, those type of things. I'm at a training center, so I've been training residents and fellows, more recently fellows, for the last 20 years. And I can tell you that that is what I teach all of the fellows. If you do not think as a surgeon you can do equally as good of a job doing it MIS or minimally invasive, you should not be doing minimally invasive surgery.
There's been a lot of research, comparative research, where they studied patients who've had a less invasive approach and compared them to in the same study to a different patient population that had a traditional approach. So we call that a comparative study. And they've done it for decompression surgery, and they've done it for fusion surgery, for 1 and 2 level fusion surgery. And what the results show that for decompression surgery and for fusion surgery, the results in the short term appear to be in favor of a less invasive option. But in a longer term, when we look at the things that are meaningful and how we measure those, and we use patient-reported outcomes. So those are the tablets and those are the questionnaires that patients fill out before and after their procedure at various time points after the surgery. And so, but in the long term, most, not all, but most of the studies demonstrate that there's no definable difference in terms of how a patient is perceiving their outcomes. So that would say that despite the apparent short-term benefit, again, less narcotics, shorter hospital stay, et cetera, in the short term, those differences are not as obvious. They don't exist at 1 year or 2 years.
But for the most part, at least in adult deformity, at least large deformities, I think there's still a substantial role for open surgery, so maximally invasive type surgery.
First of all, the skin incisions tend to be smaller. And so when you do these incisions on either side through the muscle belly, you can directly focus your surgical technique on the area of the problem, or what we call the pathology. Versus if you make midline incisions, you have to expose more of the muscle off of the spine. And when you retract that muscle from the spine, it does not have its adequate blood supply for a period of time. So blood supply is very, very critical to muscle health. So if you lose blood supply for 2 or 3 hours, it tends to not recover as well. And we've done many studies looking at post-operative MRIs, which is probably one of the easiest ways of looking at the health of muscles. And if we make larger midline incisions, that muscle tends to be much more damaged than if we do the smaller procedures where we do the side-to-side or paramedian exposures.
Please consider giving to the foundation to help support this education and to carry this message of hope to all of those across America.
Spine Talks is a program produced by the National Spine Health Foundation. For more information or to make a donation, visit spinehealth.org.